I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Heart disease is our number one killer after decades of cholesterol-lowering treatment. What else causes heart attacks? This is the People's Pharmacy with Terry and Joe Graydon.
Cholesterol's not the only blood lipid that contributes to heart disease and strokes. An under-recognized compound called lipoprotein A is an important risk factor for cardiovascular disease.
Most people get regular blood tests for total cholesterol, LDL cholesterol, and triglycerides. Relatively few have had their blood tested for Lp(a).
Is it possible to lower this important risk factor? Does diet or exercise matter? What about niacin?
Coming up on the People's Pharmacy, is Lp(a) the heart risk no one talks about?
In the People's Pharmacy Health Headlines, the Mediterranean diet has garnered a lot of acclaim for its ability to reduce the risk of cardiometabolic disorders like diabetes and heart disease. Now, a study of nearly 500,000 adults has found that those following a Mediterranean dietary pattern are less vulnerable to obesity-related cancers. The research published in JAMA Network Open relies on data from the European Prospective Investigation into Cancer and Nutrition. Participants were recruited between 1992 and 2000 and followed for around 15 years. During that time, about 5% of the volunteers experienced a cancer diagnosis. Those who stuck closely to a Mediterranean diet rich in vegetables and fruit and low in meat and processed foods were less likely to develop an obesity-related cancer, even though there was no clear link to waist size or body mass index.
Patients who suffer from systemic autoimmune rheumatic diseases such as lupus may experience long delays in diagnosis. Not infrequently, their symptoms are dismissed as psychosomatic or all in your head. A recent study published in the journal Rheumatology found that such a misdiagnosis can have devastating, lasting mental health consequences. These may include feelings of self-doubt, shame, and suicidal thoughts. When specialists dismiss symptoms as psychological, it leads to distrust of doctors and depression. Patients with medically unexplained symptoms who were initially told it was all in their head have lasting negative mental health consequences. The authors recommend that doctors acknowledge previous misdiagnoses and consider systemic autoimmunity when patients describe a long list of seemingly disconnected symptoms.
More than a decade ago, the trial to assess chelation therapy found that active chelation therapy, together with multivitamins, was more effective than placebo chelation and placebo vitamins in preventing recurrent heart attacks. A follow-up study has just been published testing the benefits of high-dose multivitamins against cardiovascular complications in people with diabetes and heart disease. 1,000 volunteers participated for an average of 4 years. Half got 6 vitamin pills a day, while the other half got placebo. In addition, half got chelation therapy and the rest got placebo infusions. There were no significant differences in event rates among the groups, although those getting the active high-dose multivitamins had slightly higher rates of heart attack, stroke, and death from cardiovascular disease. Chelation or placebo infusion did not make a difference in cardiovascular outcomes.
The FDA has long warned doctors and patients that testosterone-containing medications increase the risk for heart attacks, strokes, and death. Men with low T were cautioned not to use this hormone unless their low hormone levels were brought on by chemotherapy, infection, or some other very serious health condition. The FDA has never appeared concerned about the effects of low testosterone levels. A meta-analysis of 11 studies involving over 24,000 men was published in the Annals of Internal Medicine in 2024. It concluded that low T was linked to shorter lifespans and higher mortality from cardiovascular disease. Last week, the FDA changed course. After reviewing data from a 2023 study of testosterone replacement therapy, the agency decided to remove its boxed warning about cardiovascular outcomes such as heart attack, strokes, or death. It will, however, add a caution about increased blood pressure. The study upon which these changes are based found an increase in systolic blood pressure of zero point 0.3 points after 6 months.
People dealing with cancer may feel anxious or depressed, older people particularly. Doctors often address the psychological effects with prescription drugs, but those sometimes interact with cancer therapies. A meta-analysis of 27 studies, including nearly 2,000 participants, found that exercise can reduce depression and anxiety linked to cancer treatment. Mind-body exercise interventions were especially helpful. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Cardiovascular disease remains the #1 killer in the United States, despite 3 decades of statin treatment. Drugs like atorvastatin, simvastatin, and rosuvastatin are taken by nearly 50 million Americans. They dramatically lower LDL cholesterol.
But LDL is not the only risk factor for heart disease. Today, we're talking with one of the pioneers in understanding and researching lipoprotein A, a little-known heart risk factor. Statins don't lower this dangerous blood lipid. What can we do about it?
To find out, we are talking with Dr. Sam Tsimikas. He's a professor of medicine and cardiology and director of vascular medicine at the Sulpicio Cardiovascular Center in the Division of Cardiovascular Medicine at the University of California, San Diego.
Welcome back to the People's Pharmacy, Dr. Sam Tsimikas.
Thank you, Joe and Terry. Glad to be back with you again.
We are so happy to talk to you. There's so much new and exciting that's been happening in the world of cardiology. But first, we think of you as Dr. LP little a, lipoprotein A. Please tell our listeners who may have not heard you the first time we spoke with you, what is LP little a and why is it important?
Yes, LP little a was short for lipoprotein little a. That is what we call a lipoprotein, which means it's a circulating particle in your blood that accumulates cholesterol and something called oxidized phospholipids. And it's a particle that actually causes heart disease. And it's been identified as being a risk factor for heart attack, stroke, aortic valve disease, and peripheral arterial disease. And so it's something that's not desirable to have too high a level in the plasma and in your circulation.
Dr. Tsimikas, making an analogy to cholesterol. Cholesterol, when it's too high, can cause a lot of damage. But if you have no cholesterol at all, you're in trouble. Cholesterol actually has a role to play in the body's overall health. It's essential for our bodies to make hormones. It's needed for cellular membranes. What sort of role does LP little a play in the body?
Yeah, why do we even have LP little a?
That's a great question. And unfortunately, we don't know the answer to that. What we do know is that it's genetically determined, which means it's inherited from one or both parents. And quite a few patients or people have elevated levels, so about 1 in 5. And the evolution of that is not clear. It's certainly not anything to do with cholesterol per se as a beneficial function, because cells can make their own cholesterol when they need it. They don't need necessarily a lipoprotein to deliver it. There's some theories why it's evolved. Some of them have to do with the fact that it's related to a coagulation factor called plasminogen that's involved in breaking apart blood clots. So there's a theory that we have LPA to actually help form blood clots to prevent us from bleeding to death in certain situations. A good example is childbirth. So if the mother dies, the baby will die. And so people have low LPA will not reproduce later, but the people have high LPA where the coagulation system could have worked better may survive. So that's a hypothesis. There's also some theories that it may be involved in wound healing and maybe perhaps if with fighting parasites. These are all hypotheses. We don't know the real answer at this point. What we do know, though, is in modern society, where a lot of these issues aren't as much of a problem, we don't need it. And the downside is if you make too many blood clots, is you can get heart disease. And so maybe it had an old primordial beneficial function, but that function no longer seems to be necessary. And now we get all the bad things from it, which is it gives us a higher propensity to cause atherosclerosis and blood clots and cause heart problems.
So, Dr. Tsimikas, I think people are very confused because they've heard about all of these things that could be bad for their heart. Total cholesterol, LDL cholesterol, triglycerides, and then there are a bunch of other things like VLDL. Where does Lp(a) stand when it comes to all these nasty things that are floating around in our bloodstream?
Yes. So Lp(a) is actually, even though it's a lipoprotein, it's independent of the risk of all those other bad guys that you just mentioned. So it doesn't actually correlate. Like if you have high of one of those other ones, like LDL cholesterol, it doesn't mean you're going to have a high level of LPA. They're totally independent of each other. So unfortunately, it's kind of an equal opportunity bad guy in the sense that it does its own thing and has its own pathway for causing disease. And one of those is that it accumulates so-called oxidized phospholipids when it circulates. And those are chemical modifications that occur through a variety of reasons, including just regular cellular metabolism, and those can cause inflammation. So if you have high levels of LPA, you now have the propensity to accumulate oxidative stress through these oxidized phospholipids, and now you have this propensity to get cardiovascular disease because it acts as a inflammatory molecule. And so the bottom line is if you have high LDL cholesterol or high triglycerides, those cause their own issues. If you have high LPA, it's going to cause an additional risk independent of those other two.
Dr. Tsimikas, you suggested that 1 in 5 of us has elevated Lp(a) as a result of genetics. Does that mean it runs in families? Could we look at a family tree and say, oh, yeah, Grandpa Harry died young of heart disease. I should have my Lp(a) tested?
That's exactly right. And this is how we practice in our clinics. So the way it's transmitted genetically is what we call autosomal codominant, which is a facet term that basically means if one of the parents has elevated LPA, then about 50% of the children will have elevated LPA. That just goes through typical Mendelian genetics. So you can trace LPA in the family if you had a way to do it, to millions of years. So if you identify a patient with an LPA that's, say, 3 times above normal, somebody in that family going back millions of years had the exact same thing. So it's been tracked down all the way through millennia to current day. And so because of that, that means that it keeps propagating. So every time somebody has a level, half of the kids will get it. So it never goes away out of the population.
Now, most of us can't track our ancestry back millions of years or even more than 100 or 2 years. So how would you know if your Lp(a) were too high?
It's very simple, actually. It's a simple blood test, just like you get your cholesterol levels checked. You have to make sure your doctor orders an LPA. So you have to ask for that. It's not part of the typical lipid panel, but it's a very easy test to do, and it's relatively inexpensive now. And so if you identify a person, patient A with it, then what should happen next is the siblings should get screened, and then the children, if they're old enough, and or the parents. So that person's parents. And then what you're going to find is if you have one person with high LPA, probably half of those people will likely have also elevated levels. So that's what you call cascade screening of the family, and that's how you can identify additional family members that may be at risk.
So, Dr. Tsimikas, it gets very confusing very fast. And the reason I say that is because there are two ways of measuring LP little a. There's the milligrams per deciliter, and you'll need to tell us what the level that we should be below, 53 or 50, because I've seen both. And then there's something called nanomols per liter, and that's around 112 to 125. So please, unlike something quote unquote simple like LDL cholesterol, you're supposed to be under 125 or now 100. And some doctors, some of your colleagues say it needs to be below 75. And everybody goes, okay, I know my LDL cholesterol level, but how do I know what's a bad LP little a number?
Right. That is true. There are two methods to measure it, although that's changing. So the milligram per deciliter method is the older method, and there's a newer method where it's in nanomoles per liter. At the clinical level, the patient level, we don't have to worry too much about the specific ways to measure it. We just have to know what you suggested is what is an abnormal level. So if you look at your laboratory report for milligrams per deciliter, the level that's called abnormal is above 30 milligrams per deciliter. And if you look at nanomoles per liter, it's above 75. Now, there's a gray zone there between 30 and 50 on the milligram per deciliter and 75 to 125 for the nanomole per liter. So if you want to be in the safest zone for LPA, it should be under 30 milligrams per deciliter or under 75 nanomoles per liter. And just when you get your lab report, just check to see what the units are. It tells you what the normal should be. And so you can tell from the lab report what would be the ideal level depending on what the unit is. The risk of LPA then rises linearly as the level goes up. And so if you wanted to estimate what your risk is, kind of the higher, the more the risk. The numbers can go up to, 250 milligrams per deciliter and over 500 nanomoles per liter, depending on the laboratory that reports them.
You're listening to Dr. Sam Tsimikas, Professor of Medicine and Cardiology and Director of Vascular Medicine at the Sulpizio Cardiovascular Center in the Division of Cardiovascular Medicine at the University of California, San Diego.
After the break, we'll find out more about the risks of elevated levels of LP little a. Do they cause anything else besides heart attacks?
Could lipoprotein have an influence on heart valves or peripheral arteries?
Researchers are developing drugs that can lower LP little a. Do they reduce heart problems?
What's the safety profile of the new drugs?
Does it make sense to take a statin with one of these medicines? Since statins raise LP little a, it's a bit like driving with your foot on the brake and the gas at the same time.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is made possible in part by CocoVia, backed by 20 years of scientific research and the maker of the most proven and concentrated flavanol extract in the market today, CocoPro Cocoa Extract. Cocoa flavanols are among the most studied plant-based bioactives today and are clinically proven to promote cardiovascular and brain health for the long term, supporting a strong heart and better memory.
Get 15% off your order of any CocoVia product by using the discount code PPOD15. Learn more at CocoVia, and remember that discount code is PPOD15.
These statements have not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by CocoVia dietary supplements. CocoVia Memory Plus is formulated with 750 milligrams of cocoflavanols. More information at cocovia.com.
Today, we're talking about an underappreciated heart risk factor. What do you need to know about lipoprotein A?
Our guest is Dr. Sam Tsimikas, Professor of Medicine and Cardiology and Director of Vascular Medicine at the Sulpizio Cardiovascular Center in the Division of Cardiovascular Medicine of the University of California, San Diego.
Dr. Tsimikas, you have told us that when our Lp(a) number is elevated, and just for argument's sake, let's just say it's over 100, on the nanomolars, maybe 150, and that gets you nervous as a cardiologist. Besides increasing our risk for a heart attack, a clogged coronary artery, what else do high Lp(a) levels contribute to? We've heard things about heart valves, calcified heart valves, or aortic valve stenosis. What does that mean? And then something else called PAD, peripheral artery disease. Why are those things nasty?
Okay, so the bottom line is when LP is generated, it's made actually in the liver, and then it circulates. And the first thing that it sees when it circulates is all your blood vessel walls, not your veins. It sees your veins, but it doesn't seem to cause a problem in the veins. Most of the problem is associated in the arterial system. And so what are the key parts of the arterial system where it would cause clinical symptoms? One is it can clog up the arteries on the surface of the heart that supply the heart muscle. We call that coronary artery disease. So that's what typical you get when you get a heart attack. And the consequences of a heart attack is that you could also get heart failure. And so heart attack and heart failure are the two things that would be related to coronary artery disease. If it causes a blockage in your carotid arteries, which are in your neck, or the arteries in your brain, then you can have a stroke related to a blockage in the brain. The LPA also is a very sticky particle, and it will stick to the valve leaflets. So the valve in your heart, the aortic valve, every time your heart squeezes, the leaflets open, the blood comes out, and then it closes to fill. And those leaflets can get calcified and thickened. And when they do that, they don't open properly, and they cause a difficulty of the heart ejecting the blood. And the analogy for that is the garden hose. Okay, you have turn on the water, it puts out a certain amount of water per second. If you put your thumb on it, and then the same amount of water is coming out, but because you obstructed that orifice of the hose, it comes out much faster because you haven't slowed the flow of the water yet. This is the same thing that happens to the aortic valve. It gets narrowed, and now the pressure in the heart has to go up, like the pressure in the hose, and that causes a murmur that doctors can hear. Peripheral arterial disease, or PAD, is an analogy to coronary disease, except it happens in the arteries in your thighs and in your calves. And so those kind of blockages then will cause you to have pain when you walk in your calves or your thighs. And so the bottom line is anything related to your cardiovascular arterial system is where LPA seems to cause a lot of issues, not so much in other parts of your body.
But it sounds like Lp(a) is a bad actor. And up until fairly recently, there wasn't much you or your colleagues could do to lower Lp(a), but all that is changing. And that may have accounted for why a lot of doctors, your colleagues, didn't test for Lp(a) because there wasn't much we can do about it. You know, you could exercise all you wanted to, and you could eat a really great diet, but apparently those lifestyle things didn't help very much. But now, Dr. Tsimikas, you have drugs. Tell us about them.
Yeah. So Lp(a) is made by the liver. So even though it causes arterial disease, it actually originates from the liver. So you can think of the liver as the factory that makes too much of it. And so the way that we've conceptualized how to deal with this issue is to develop ways to prevent the liver from making that protein, but not affecting everything else the liver does. So a new class of drugs have been developed called antisense oligonucleotides. Long word. It means that you can use a a way to deliver a drug that goes into each of the cells in the liver and finds where the message is being given to make the ApoA component of LPA, the protein component. And what these drugs do is they bind to the message that will make protein and induce it to be degraded. And they only do that to that. They don't affect any of the other 20,000 genes that are unique for normal function. And so it's a very specific way to say to the liver, please stop making LPA. And the prototypical drug for that is called pelacarsen. It's an injectable drug. You can't take it orally because it gets degraded, so you have to inject it under the skin once a month. And that is the drug that's leading the way right now for therapy to lower LPA. And that drug on average will lower it about 80%, whereas the prior therapies could lower it 10, 20, 30. So it's a big advance, and it's very specific to that. It doesn't really affect other things in the body per se. And so because of that drug and because of the success of that, now there's about 10 companies working on additional drugs and other ways to lower LPA levels. And there's a whole series of clinical trials going on right now to prove that what we call the LPA hypothesis, which is if somebody has high LPA and you lower it, do you just lower the level or do they actually have a clinical benefit? What we want to see is, yes, we can lower the level very well right now, but we have to prove that causes a beneficial effect. And with these trials that are now 10,000 patients large over 5 years are testing whether lowering LPA will reduce the risk of a heart attack, a stroke, peripheral arterial disease, and aortic stenosis. And so there's a lot of efforts going on through a lot of investigators, a lot of sites, probably over 1,000 hospitals, multiple companies, multiple institutions are working on getting a therapy for all of these patients.
Dr. Tsimikas, let me see if I understand this correctly. You're saying that the especially pelacarsen, which was the first in this bunch of drugs that can lower LP(a), but there are several, and you say they do a very good job of lowering LP(a). That much we know, but what we are still trying to learn is, does that make a difference for whether or not people avoid heart attacks? Do I have that right?
Yeah, and that may sound counterintuitive to some folks because we know on the one hand, if you have high levels, it puts you at higher risk of having a heart attack, let's say. It's puts you at higher risk. It doesn't mean you're going to have one. So it's a risk factor, not a disease per se. The disease is atherosclerosis. The risk factors, LPA and the other stuff that you mentioned, smoking, diabetes, hypertension, all those are risk factors for getting atherosclerosis and having heart problem. That we know very well. All the studies are very consistent with it. What we don't know is, and it makes intuitive sense it would work, but you have to prove it. If you lower the level, so if you have a patient with 100 and one with 20, if you get the 100 to 20, is that patient risk going to go down? And the FDA will not approve these drugs just for LPA lowering until we know that we also get a clinical benefit from that. I think what will happen is if we get 4 or 5 trials that all show the same thing, you lower LPA 50 points, you have a 20% risk reduction, then eventually people will accept it as a surrogate biomarker to say, well, you don't have to keep doing these trials, just lower the LPA as long as that's safe, you can actually use the drug. So what you're seeing is the very early phases of developing a therapy for something that we've never had a therapy before. So the proof required for that kind of therapy, particularly since there's going to be 1 in 5 people affected, and a lot of people may be using these drugs, we want to make sure it actually helps them. And we don't want to just put the drug on the market just to lower LPA levels. We have to prove it's beneficial beyond that.
So inquiring minds want to know, Dr. Tsimikas, you've got your ear to the ground probably better than almost anyone in the world. I mean, you were an early adopter of the LP little a hypothesis. You've been testing it clinically. Are you hearing rumors? Are there rumbles? Are there whispers any place out there in the cardiology world suggesting that there might be a benefit clinically? We know that we can lower the LP little a levels with these drugs, these so-called ASOs, antisense oligonucleotides. But is there any little hint that there may be benefit?
I think there is. First of all, on the ongoing trials, everybody's blinded. And so nobody can know if the patient's on drug or placebo. And so we don't know from the ongoing trials whether there's any potential benefit. What we can say is that the pelacarsen trial is fully recruited as of the middle of 2022. And so it's just about towards the end where it might read out, in the next year. And so we're going to have the answer from that trial the soonest, within about, let's say, 12 months plus minus. It's not really clear when it will end. The other trials would take a couple of years longer or 4 years longer. However, what about before these trials? What tells us that there may be a benefit? I would say there's a couple of places where we learn that lowering LPA may help. One is there's a group of patients that have had multiple serious cardiovascular issues and continue to have them. You treat everything you can. The only thing they have is high LPA. Those patients often will undergo apheresis, particularly in Germany where it's approved.
Well, what is that?
That's a dialysis-like procedure where you take the blood out from one vein and you clean it you take the LPA out and you give the blood back. Those patients do a lot better. They have like a 90% reduction in new episodes of cardiovascular events if you do that. And so that tells us that procedure, which is very invasive and is very hard to do in everybody, but there's some suggestion those patients benefit a lot. The other place that we've had some is the more recent PCSK9 inhibitor trials.
Mm-hmm.
These are monoclonal antibodies that are injectable that lower your LDL, but they also lower LPA about 25%. And when those studies are analyzed, what we understand is that the lowering of the LPA, even though it's modest, seems to be associated with an outsized benefit in those patients if their LPA is elevated. And so the apheresis data and the recent PCSK9 inhibitor trials are suggestive, not proof, but suggestive that you do get benefit from the lowering LPA. The ultimate answer was going to be from these ongoing trials because they're going to lower LPA a lot more, 80 to 95%. And we'll know definitely these next 5 years, we'll know everything we need to know about lowering LPA and the risk reduction we might get from that.
Dr. Tsimikas, one thing we always want to know about a new drug or a new class of drugs, and that's what we're talking about here, is a whole new class of drugs, is what's the safety profile?
Yes, that's a great question. And so what ends up happening is when you do the early trials, there's not a lot of patients. There are several hundred. And often only follow for a year. And that's another reason why these trials often go 5 to 6 years in a lot of numbers. So to give an example, the Horizon trial with pelacarsen has 8,300 patients that are going to be followed for over 4 years on average, some 6, some 3. And then we're going to be looking at the safety from those studies. So the typical things that, we look at, do they have reactions where you do the injection on the skin? Do they have liver issues? Do they have platelet issues? Do they have something weird that nobody's thought about? Is there, like, for example, more diabetes? All of these things can't be seen in these small, short trials. And one of the things that you have to balance, and this is what the regulators do, it's so-called risk benefit. You have a risk of a patient, and then you have X amount of benefit, but you also want to make sure the drug is safe and effective. So there has to be a balance, which is a net positive for safety and effectiveness. And that's part of the regulatory pathway. So I would estimate the 3 major trials that are going on right now, together we'll have about 30,000 patients followed for about 4 years on average. That's going to be a very large database for us to feel confident that we're going to pick up all these rare things that you might not see if they happen to occur in these smaller trials. And so that's going to be part of the equation. Before they get on the market, they have to pass that test that they're going to be safe and effective and for them to get approved for general use.
Dr. Tsimikas, we just have about 2 minutes before the break, and I do have one bone to pick with you. And that is every one of your colleagues, and I suspect you yourself, believe that statins are the answer to heart disease. And so every one of these clinical trials, I think, has a statin as the baseline. So no one is just getting one of these anti-Lp(a) drugs by itself. They're getting a statin plus an ASO. So the problem is an article that you wrote titled Statins and Increases in Lp(a), an Inconvenient Truth That Needs Attention. So in the minute that we have left before the break, your thoughts on driving with your foot on the brake and the gas simultaneously.
Thank you for bringing that up. Well, I think what it speaks to is, LDL and LP independent risk factors. And what the point of that paper was that just because you treat the LDL does not mean you should ignore the LPA. Unfortunately, statins don't lower LPA. They tend to be neutral, or as that paper showed, raise it about 20% of the time. So the message, I think, from that paper and to my patients is, and to the world in general, both of these should be treated if they're abnormally elevated. And so, but the answer is statins aren't going to be the answer for patients with high LPA. They're going to need to have a specific therapy that addresses the LPA. Statins are good for lowering the LDL, and they're going to get rid of that risk, but they're not going to really affect LPA risk. We need specific drugs for LPA. At some point, if you have a patient whose only risk factor is LPA, they may not need a statin, and you just lower their LPA. So that's where we're going with this. I don't know if it's going to be a minority or a majority, but that's where the field, I think, needs to go. We have to address each individual risk factor on its own merits and not say we're treating one and we can ignore the other.
You're listening to Dr. Sam Tsimikas, Professor of Medicine and Cardiology and Director of Vascular Medicine at the Sulpicio Cardiovascular Center in the Division of Cardiovascular Medicine at the University of California, San Diego.
And I'd just like to spell Dr. Tsimikas' name. It's T-S-I-M-I-K-A-S. And he's actively involved in this development of antisense oligonucleotides, ASO. It's time for a short break. In just a minute, we'll find out about other ways to lower Lp(a).
Some cholesterol medicines like alirocumab and evolocumab can lower Lp(a) as well. The brand names are Praluent and Repatha.
We'll also talk about coronary calcium scans and what they can tell you.
Is there a role for niacin? It isn't expensive, and it does lower Lp(a).
To control Lp(a) now, before the new drugs become available, what should we be eating?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by CocoVia dietary supplements, cocoflavanol supplements to support cognitive and cardiovascular health. More information at cocovia.com.
Today, we're looking beyond total cholesterol, LDL cholesterol, and even HDL cholesterol at another critical risk factor for heart attacks, strokes, and other serious cardiovascular complications.
Very few people have been paying attention to lipoprotein A, but it's extremely important. Do you know your LPA levels?
Could something as affordable as niacin, a B vitamin, help lower Lp(a)?
We're talking with Dr. Sam Tsimikas, Professor of Medicine and Cardiology and Director of Vascular Medicine at the Sulpizio Cardiovascular Center in the Division of Cardiovascular Medicine of the University of California, San Diego.
Dr. Tsimikas, what about other ways to lower LP little a? I mean, one of the reasons I think that a lot of your colleagues have not bothered to test for LP little a is that they thought, well, there's nothing I can do about it. Diet, exercise, it won't help. So you've talked a little bit about PCSK9 inhibitors, and could you please mention the brands so people will know what we're talking about? And then what should someone who discovers that they do have elevated LP little a because they've asked their doctor for a blood test, what should they be doing?
Okay, those are great points. So if a patient has elevated LP little a, I think the first thing that should happen is they should just look at their overall general health. What else could be contributing or making that LPA worse? So the things that they're very typical. So, does the patient smoke? If the answer is yes, that needs to stop. Is there diabetes? Yes, that means weight reduction, and it means, keeping the blood sugar well controlled. Are there other risk factors that could be addressed up front? So once all that happens and you address as much as you can, the next question is there family history? If there's a family history, that puts the patient at higher risk for having LPA-driven disease, particularly if the member of the family was young. One thing that's unique about LPA is that the levels that you have at about 6 months of age, you tend to have the rest of your life. They fluctuate plus minus 20%, but if they're elevated when you're 50, they were elevated when you were years old. And so what happens is you accumulate a risk from a very young age. LDL for most people tends to be low until they become middle-aged, then it goes up. And so when you see a family history, that puts the patient at a higher risk. So what I often will recommend to my patients is if I'm not sure which way to go and how aggressive to be, I often will get a coronary calcium scan and assess whether the patients have coronary calcium. If they have calcium, that puts them at much higher risk than if they don't. And so that makes me want to be a lot more aggressive with all of the risk factors, including the LDL cholesterol. So I think we do some screening tests, blood tests, all their lipids, diabetes, and then possibly a coronary calcium scan. So now, what do you do with all this information? Besides general hygienic measures to basically just make sure that they're doing everything they can with their health, there's a couple of things that we can do. One is if the LDL is above where we want it, then they certainly should be treated for that. And there's a variety of ways we can lower the LDL. If they have a lot of coronary calcium or they have coronary artery disease, a strong case can be made for them to go on a PCSK9 inhibitor that you mentioned. And the two brands, there's actually 3 brands that are approved right now. There are 2 antibodies, and there's something called a short interfering RNA. And the brands are for the antibodies are Praluent and Repatha.
Mm-hmm.
They also have generic names. And then the injectable is called inclisiran. So those PCSK9 inhibitors could be used, but they're not approved for high LPA. So it's the art of medicine. Some insurance allows it, some it doesn't. It depends on the risk of the patient. And so it's an individualized decision whether to try that or to try to get approval for it. They're not cheap. They're over $5,000 a year. And so most patients will not be able to afford those. So we often will have to go back and forth with the insurance company to deal with that. Unfortunately, that's the reality right now. That's a temporizing measure until we have more specific drugs. There's a couple other things that patients can do. I actually have a lot of patients on niacin, which is generic and over the counter.
And
There's
inexpensive.
some controversy. Oh, sorry.
It's because it's generic and over the counter, it's not expensive.
That's correct. It was, niacin has been around for 50 years. There was a brand name for it. There's a sustained release version of it. The issue with niacin is it's hard to tolerate for about half of the patients. And the ones that tolerate it do quite well on it, but there are some side effects that people have to watch out for. including diabetes. It can raise your blood sugar. And so if somebody has borderline blood sugars, that's probably not a good drug for them. It also has some skin side effects, flushing in particular. And part of the reason it's not used as much is some of the recent trials where they've added niacin on top of statins haven't shown additional benefit where PCSK9 inhibitors have. And it's possible because PCSK9 inhibitors lower the LDL a lot more.
Right.
I still have patients on niacin, but most people aren't using it anymore as a new therapy.
But you say that until your patients have access to hopefully what we will discover are effective drugs to actually lower Lp(a), you can help them with niacin as long as they tolerate it. What sorts of doses are people using?
Yeah, so to get an effect on LPA, you need to use at least 1,000 milligrams a day, and to try to get it to about 1,500 to 2,000. And that will get you about a 20 to 30% reduction in LPA. The issue, of course, is nobody's been able to link that reduction with a benefit, like what's happening now in the trials. So what you'll see from a lot of physicians is, well, there's no outcomes data with niacin. I know it lowers LPA, but I don't know if there's any clinical benefit outside of that. Now, on the other side of the coin, nobody's done a trial in high LPA patients with and without niacin to see the benefit. So we're dealing in a gray zone where there's a lot of opinions, and usually this is where the controversy comes. You don't have enough information. You can use expert opinion. You can use people's experience and biases. So it becomes a little bit controversial in that regard.
Well, Dr. Tsimikas, when you and your colleagues were enthusiastic about niacin, dial back about 20 or 30 years, they often recommended some aspirin about a half an hour to an hour before the niacin, and they recommended taking the niacin with food and building up the dose very gradually so that the body adapted. Is that something you still contemplate when you feel it's important to treat somebody?
Yes, that's exactly correct. That's what we've been teaching patients for a long time to do, because the aspirin minimizes the flushing that they get. Also, patients after, if they can get through about 6 months, they often will develop tolerance to the flushing, and then they continue on it for a long time. They'll get occasional flushing. The flushing is not a serious side effect. It's not a permanent issue. You feel hot, you have pins and needles in your body, and it goes away in about 20 minutes. For some people, it's worse, but it's basically just dilatation of the skin. It's kind of like, it kind of makes you feel like you're in 100-degree weather for 20 minutes. Some people hate that, understandably, and some people can tolerate it, but it's not an ideal side effect, honestly, because of the lifestyle issue. Now, the aspirin is a very important part that's emerging now. I think the general sense is that if you haven't had a heart issue or a stroke, that on average right now, aspirin doesn't seem to help based on recent trials. Now, if you had a heart issue, then it does help. So people have had a heart issue, stents, heart attack, they all should be on aspirin. If you haven't, it's sort of been relegated to extremely high-risk patients. However, we've actually started thinking about this a little bit more specifically to people with high LPA, because one of the side effects or the complications of LPA when it's elevated is blood clots. So we started working with some large databases, and we've been able to demonstrate initially that people that have genetically elevated LPA, if they take aspirin, they can actually reduce their risk to about the way it would have been if their LPA was normal. Now, this was done with genetic tests for LPA, not with blood tests of LPA. We are now repeating this 12,000 patient study with a blood test of LPA in our lab this year. And so we will know at what level of LPA, if any, there's a benefit from taking aspirin. What I do in my clinic is, if I have a patient with high LPA, that particularly if they have other risk factors or a family history, I have a discussion with them and we go over the risks and the benefits of taking aspirin, because a potential serious complication is bleeding, and serious bleeding. So you have to weigh this decision carefully. It's not just like as simple as taking aspirin. And so in some patients, I have them take a baby aspirin if they have a very strong family history, along with a lot of coronary calcium and other risk factors. while we wait. Now, this is also the art of medicine. It's not in a guideline, but we're trying to get information to see if it's going to actually help patients as a way to temporize. So we may not need to lower the LPA as much. Maybe they just need some aspirin to prevent the blood clots from forming. So that's another area of this field that's emerging. Who should be on aspirin? And it looks like high LPA patients may be a subset of people that could develop or derive some benefit, but we need additional proof, and we'll get that in the next couple of years.
Dr. Tsimikas, we have a lot of listeners who are interested in doing whatever they can to maintain or improve their own health, and they want to know, what should I be eating? How much should I be exercising? Do you have any advice for them?
Yes. So the answer, I think, for exercise is, if half an hour, just walking, is good. Exercise helps everything essentially, within reason. So I would say activity should be just part of normal lifestyle, irrespective of the LPA or not. But it would certainly help if people have high LPA. Diet is an emerging area that's has now a little bit of controversy. So what's happened with LPA is all the things, or most of the things that lower LDL, tend to raise LPA a little bit. So a good example is saturated fat. Saturated fat, if you eat too much, can raise your LDL, but it seems to suppress your LPA about 10%. Now, I don't recommend people eat a lot of saturated fat because on average, it raises more your LDL than it lowers your LPA, so you're worse off. And vice versa, the same thing. So unsaturated fat does the opposite. And so the small effects of diet on LPA in terms of the plasma level, but diet is tricky because it affects a lot of things. So it can affect your glucose, it can affect your other lipids, your triglycerides, and your LDL and your LPA. So you can't take diet in isolation. I would say this, in general, the Mediterranean diet is probably the one that people will stick to the most. It's palatable, and it has primarily, its fat is olive oil, which has additional beneficial properties on oxidation of the lipids and other properties.
Well, I was going to ask you about the Mediterranean diet because we recommend it so frequently, and because your last name is Tsimikas, suggesting a Mediterranean connection.
That's why I do have a bias there. We have it published as a beautiful paper way back on olive oil and the Mediterranean diet. But that being said, if a patient has glucose intolerance, then they need to cut down on the carbohydrates.
Mm-hmm.
So there's a lot of people doing ketogenic diets. Those are a little bit tricky for people with cardiovascular disease because they can raise the LDL a lot. I don't recommend that unless you keep your LDL controlled. It's not really a good therapy for high LPA. But moderation of caloric intake is probably just as important as what to eat, how much to eat, and the how much is always an issue for everybody, including myself. So the how much, if we can find a way to kind of minimize that, that will lend a long way. Exercise is a way to mitigate that. You can eat a little bit more if you exercise. If you don't exercise, you eat a little bit less. Mediterranean diet is probably good because it has fiber, it has antioxidants, and it's tasty. And you can stick with this a long time instead of bouncing around in different diets. There's also now for patients that have obesity and diabetes, GLP-1 receptor agonists, and those should be taken advantage of if somebody has an issue with diabetes or cardiovascular disease, and they could benefit from that. Why not? There are some side effects with those, but that could kind of speed up some of the behavioral modifications or work along with them if needed.
Now, Dr. Tsimikas, we have a minute left, and so I just want you to wrap up very briefly, if you don't mind. If somebody goes forward and has their Lp(a) blood tested and they're too high, while we wait for the new drugs and the results of the clinical trials that you and your colleagues are doing, what can they do to reduce their rather substantial risk of calcification of their valves, of heart attack, or peripheral artery disease? Briefly, tell us about aspirin, tell us about niacin, tell us what they should and shouldn't be doing as far as their diet.
Sure. The kind of bottom line is make sure you find a physician who's interested in preventative medicine. It doesn't have to be cardiology, but preventative cardiovascular disease. Keep your weight as normal as you can. Control all your risk factors. That includes diabetes, high blood pressure, obesity, etc. If you have a family history, particularly if it's significant family history of cardiovascular disease, aspirin with an appropriate risk benefit discussion is an option. If your LDL is elevated, that should be reduced either with a statin and or a PCSK9 inhibitor. And we're in the at the end of the light is at the end of the tunnel for knowing whether lowering LP with specific drugs will help us. Stay on top of the news. We'll know in about a year, and then then hopefully we'll have a lot more specific options. So we don't have just non-specific ways to treat it. We'll have specific ways to address it that goes to the genetics of the problem, and that hopefully will be the way to manage this in the long term.
When we spoke to one of your colleagues, Dr. Tsimikas, Dr. Steve Nissen, about statins and calcium,
Yes.
he said two things. Number one, he doesn't believe in the calcium score. And number two, that statins will sometimes cause calcium in the coronary arteries to harden. And that's a good thing. It stabilizes calcium.
Yes.
So I'm kind of curious, your perspective on calcium, especially if someone has high Lp(a) levels.
Yeah. What's interesting is if you try to do a correlation between the amount of calcium in the coronary arteries and the Lp(a), the correlation is very weak. It's much stronger for LDL and other risk factors. And so that begs the question, well, if it's not working through calcium, what is it working through? We think LP is a later stage issue in the so-called atherothrombosis area. It's more the inflammation that probably is triggered by its content of oxidized phospholipids and the propensity to form blood clots. So it's kind of a later stage effect of triggering an event. Now, the calcium is an interesting one. It's very clear. If you have no calcium, you're going to do much better than if you have a lot of calcium. I believe calcium is a good prognostic indicator if you don't have a statin on board. But once you give a statin, he's absolutely correct, you can calcify faster. And the reason for that is you have a plaque that has lipid in it. And when you do a calcium scan, you can't see it. You give a statin, the lipid comes out, and now the plaque heals, and part of the healing is calcification. So when you give a statin, you don't want to monitor the calcium score and say, oh, look, the statin is not making it go away, because it won't. It actually, if anything, it makes the plaque from a lipid-rich, high-risk one to a calcified one. You don't want to have any calcium, but you're better off having a calcified plaque with no lipid in it than a lipid plaque with no calcium. So it's a little bit of understanding where you are in the process of the disease. I think part of the initial comment about I don't believe in calcium is there are some physicians that say, well, I'm going to treat anyway, so I don't care what the score is. If you have X, Y, Z risk factors, I'm going to treat you. So the bottom line, I think, is calcium scans and statins. That's not the way to follow patients for whether they're benefiting from a statin by doing a calcium scan. That, I think, is known. And so, yeah.
So, Dr. Tsimikas, there has been a lot written about the benefits and risks of statins. And I think a lot of your colleagues, cardiologists, say, oh, statins save lives, lots and lots of lives. And anybody with an elevated LDL cholesterol should absolutely be on a statin no matter what. And yet the American Heart Association came out just recently and said heart disease is still the big number one killer in America. Almost 1 million people die every year from cardiovascular disease, heart attacks, strokes, and ancillary problems. And I'm asking myself, well, wait a minute. 50 million people are taking a statin and have been taking statins for decades. Atorvastatin is the number one drug in America and has been for quite a long time. And people have dramatically reduced their smoking. It's been an impressive public health initiative. So why, after decades of statins and tens of millions of people taking atorvastatin and rosuvastatin and simvastatin, why haven't we budged the needle?
Well, that's a complicated question. I think we have competing issues. The trials are very clear, and there's probably over 1 million patients in trials with statins showing a benefit. And so one way you can gauge who believes that is if you look at cardiologists, I would say, 80, 90% probably take statins. And so the people that are dealing with all the complications, all the heart attacks, sudden deaths, day to day in real life, have probably a different perception than kind of the internet world. But we've had a gigantic increase in obesity over the last, several decades, and increasing diabetes. Smoking has gone down. Blood pressure is relatively well controlled for the most part. But so that's the good side. Lipids, the average lipid levels have declined, not LPA, but the LDLs have come down. But then other things have gotten worse. And so we're kind of in this situation where some things are getting better, some things are getting worse. For many decades, we've had a reduction in mortality from cardiovascular disease since the 60s, and now that seems to have plateaued and going in the wrong direction. I think the answer is statins don't address all of the issues that cause heart attacks. It's very simple. They don't address LPA-mediated risk. They don't really address diabetes and that whole milieu, metabolic syndrome, obesity. So if you go back to societies 100 years ago, where a lot of these current issues, like particularly obesity, weren't around, cardiovascular disease wasn't as high. So it's a complicated issue. These are risk factors. They're not diseases per se. Atherosclerosis is a disease, and there's a lot of inputs to it. And I think we have to address all of them, not just one here, one there. There's now a whole bunch of new ways to treat all of them, and including combination drugs. There'll be drugs that can lower your triglycerides and your LDL, or your LPA and your LDL. And ultimately, I have this thing called the rule of 50 that I've had on Twitter and other places, where if you have a lifelong LDL of 50 or less, LPA 50 milligrams per deciliter or less, and triglycerides less than 50, your risk of cardiovascular disease should be negligible. Now, most people can't get there. When we're born, we kind of have about those levels, except perhaps for LPA. But then as we get older, then we have much higher levels. So until we get a way to control the lipids, it's going to be hard to get what you're asking is to get it down. But we also have to control the other risk factors. And so it'll be interesting to see how in the next 20 years, as we have ways to modify the lipids and dial the number to where we want it. If we are still seeing 1 million people with heart attacks every year, then we got a problem. We have to reassess our hypotheses. I don't think that's going to happen, though, but it's probably never going to go to zero, but it should be much lower, assuming that we can control all the risk factors. If we control the LDL, but then all these other things are contributing to atherosclerosis, then that could be the explanation why people are escaping from the benefit they should get.
Dr. Sam Tsimikas, thank you so much for talking with us on the People's Pharmacy today.
Well, it's my pleasure, and thank you for asking such fantastic questions and helping your audience understand this issue.
You've been listening to Dr. Sam Tsimikas, Professor of Medicine and Cardiology and Director of Vascular Medicine at the Sulpizio Cardiovascular Center in the Division of Cardiovascular Medicine of the University of California, San Diego.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
The People's Pharmacy is made possible in part by Cocoa Via Dietary Supplements. CocoVia Cardio Health is offered in both capsule and powder formats, each containing 500 milligrams of cocoflavanols. More information at cocovia.com.
Today's show is number 1421. You can find it online at peoplespharmacy.com. That's where you could share your comments about today's interview. You can also reach us through email. We're radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider. You'll find the podcast on our website on Monday morning. This week's podcast has additional information about calcium scores and how we weigh the benefits and risks of statins.
At peoplespharmacy.com, you could sign up for our free online newsletter to get the latest news about important health stories. When you subscribe, you also have regular access to information about our weekly podcast. You could find out ahead of time what topics we'll be covering.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.